Hello, everyone. This is part one of oxygen, care of the patient with oxygen and tracheostomy care. Chapter 28 is care of patients requiring oxygen therapy. Our learning outcomes are to collaborate with the interdisciplinary team to coordinate high-quality care and promote gas exchange in patients requiring oxygen with or without a tracheostomy. And the rest are to educate both the patient and caregivers on the safety concerns, prioritize evidence-based care for patients requiring oxygen therapy or tracheostomy for problems affecting gas exchange, implement nursing interventions to decrease psychosocial impact caused by requiring oxygen or having a tracheostomy, and explain appropriate techniques to administer prescribed oxygen and provide tracheostomy care. Wait a minute, a 5-minute review of the respiratory system. This is not a complete review. You still need to review the entire Chapter 27 PowerPoint on your own. But I'm going to take a short time to just go over a few brief things. If we remember our anatomy and physiology, our upper respiratory tract is our nose, sinus, pharynx, and larynx. In our lower respiratory tract is trachea, the two mainstem bronchi, then going into the lobular segmental, subsegmental bronchi, the bronchioles, the alveolar ducts, and the alveoli. The alveolar air sacs is where gas exchange takes place. Health promotion and maintenance. Minimize exposure to inhalation irritants, both at home and work exposures. Smoking cessation, including vaping and use of water pipes and cigarette smoke. Different groups are more likely to smoke, including lesbian women, gay men, bisexual men, and women and transgender. Adults report higher rates of smoking compared to their heterosexual counterparts. Smoking is also higher among African Americans, blue-collar workers, and less educated people. The Joint Commission requires documentation of screening of tobacco use and that a tobacco treatment program is offered as part of the quality measures. Physical assessment of the lungs and thorax. Inspect the thorax when the patient is sitting upright. Observe the chest, compare one side to the other. Work from the apex and move downward towards the base from side to side. And you want to look at the rate, rhythm, and depth of inspiration, as well as the symmetry of the chest movement. When listening to lung sounds, the normal lung sounds are listed very nicely on table 27.5. The adventitious sounds that we're going to be talking about during the lectures this week are both diminished, crackles and rails, wheezing, rhonchi, coarse sounding, and then there is the pleural friction rub as well. Other indicators that we'll be talking about in our COPD lecture will be changes to both skin and mucous membranes, general appearance, looking at clubbing of the fingers, weight loss, whether the shape of the chest, as perhaps with some COPDers it becomes more barrel-chested, and endurance as far as physical activity and shortness of breath. We'll also be looking at psychosocial assessment needs, such as when people have debilitating lung disease, the financial hardships, both anxiety and stress, their coping mechanism we may be taking away from them because it very well could be the use of nicotine, and roles and relationships that may be affected. This is by no means an in-depth on Chapter 27, but there are concepts that I want to make sure that you review more in detail from that chapter. So I did want to just do a brief overview prior to going into our lecture for Chapter 28.